Voice. I shall be facilitating this afternoon along with Conrad Mitchell. I want to give a special welcome to those who are joining us for the first time, especially Mr. Marvin Ellis, who's our MRF's new adherent. So welcome, welcome. And I think you've joined at a particularly relevant time given your role at MRF, because we're going to discuss today patient-centered communication with stigma-informed and trauma-informed approach, and with a lens on identity and identity safety. And I remember the whole staff at MRF will have gone through mental health training under ITEC, the entire staff. And one of the big issues that came up was the necessity for trauma-informed care at all points in the clinical care cascade. And this is from the physician, from the care from the psychosocial staff, from the phlebotomist, from the security guard, from everybody. So this is a really, really important aspect of care, how we communicate to our clients, many of whom are coming from backgrounds that some of us could not even imagine. So I would really welcome Dr. Justin Bullock, who is here from the University of Washington, to give us a lecture on this topic. And again, Dr. Bullock, thank you so much. And we're really excited to get into it, so I should turn the floor over to you.
Thank you very much, and thank you all for having me. I'm very excited to get to talk. As you'll see, this is a topic that has a lot of personal meaning to me. I'll get more into who I am a bit as we go into the talk, so I'll save that for now. And yes, today I will focus on thinking about how we communicate through, and I'll come back to this word through, stigma, trauma, and identity. So my plan for today is hopefully I'll talk for about 30-ish minutes, and I hope we have some time actually just to have some conversation amongst us as a group. The one disclosure that I will give you is that I will talk about mental health and topics of trauma and suicidality. Everything that I share, I try to do with intention, but if you need to take a break or step away, I encourage you to do so. I use this slide as a placeholder to say that I'm going to talk a lot about identity. I'll focus on a lot of my identities as a clinician and as a human, and that I will not be able to capture all of the nuances or kind of interesting beauties of identity, but I will attempt to try to make statements that can be applied broadly to people. So I just have one main objective for today, which is to critically explore communication in the intersection of personal and professional in caring for patients with lived experience of trauma and stigmatized health conditions. And I think here I'll start with a little bit of my introduction to myself. So I am a nephrologist. So I practice kidney medicine here in Seattle, and I am a medical education researcher. And I study specifically safety in the learning environment and how safety or lack thereof influences both the sort of care delivery of medicine and also the process of learning medicine. And in this slide, I have this word critically, which is very important for me. So I identify as a critical theory researcher, and critical theory is a body of thought which really studies power, and specifically how power is linked to identity. And critical theorists would say, if you look across society, one of the original critical theorists is a gentleman named Paulo Freire. He was a Brazilian philosopher, an educator, and he has this book called Pedagogy of the Oppressed. And in this book, he writes that if you look throughout society, there are often, in many different contexts, people who are oppressors and people who are oppressed. And while in different contexts, there may be different groups who are in power or in less power, what you'll see is that there's this constant battle between the oppressed and the oppressors. And what Freire argues is much of history is spent sort of trying to battle for one dominant group, but in order to truly change society, we must exit this battle. I think that across countries and contexts, class is a very big identity. It is, well, it is both an identity group and a privilege, a group of privilege that that we see across races, genders, etc. That there are often people who have more and have less, and these are often reflected in health outcomes as well. So critical theorists really believe in this power of the story. So I'm going to spend a lot of today sort of using myself as a lens, recognizing that I am just one person, but to try and use narratives from my life, from my experiences, to unpack a lot of these topics around stigma and power. The human being is a storytelling being, and story is really how I and many people throughout the world make sense of it. So here's where I will start talking a bit more about myself. So I have bipolar disorder. I am someone who is very vocal about sort of living and practicing medicine with bipolar disorder. And specifically, a lot of my goal in talking about my mental health is really to try and challenge the notion that healthcare providers are somehow different than the patients that we care for. Because we are human, we live with disease, illness, suffering, challenges, and a lot of my sort of writing and advocacy work, it attempts to sort of give humanity to the experience of living with serious mental illness. And so just to give you all a sense of who I am and what types of stories I try to share. There's one piece that I wrote where I was in much of sort of the literature when people talk about providers with mental illness, they may hint at the topic of suicidality, but usually it's just like a very light hint, and then people sort of run away from it, and that's because within the health professions, it's often okay to sort of talk about some things in a sort of theoretical way, but when they get dark and heavy, it often is not viewed as professional. And so in one of these pieces I was sharing a moment that I had with my sister. My family has obviously been on this journey with me as I've lived with bipolar disorder. And I was in a time where I was in a very deep depression and was feeling very suicidal. And I said to my sister, I'm really sad that my 2-year-old niece isn't going to remember me, hinting that I'm feeling suicidal and that I'm thinking about hurting myself. And my sister says to me, do you think that I would ever let her forget you? I share the story because I love it very deeply, because that response is not what most people would say if someone expresses thoughts of suicide or suicidality. From that comment, what I heard from my sister was, Justin, I've seen you suffering for so long. I've seen you fight against this mental illness that has really afflicted you very deeply. And I won't be mad at you if you hurt yourself. I don't want you to hurt yourself, but my love is unconditional. I share that story because it was incredibly grounding and actually moved me away from suicide and suicidality, because I felt love and connection to human, and I felt seen. And so as we go through today, I'm going to try and unpack some of what it means, my understanding, and from some literature around how we can really communicate in ways that are very humanizing to other people, where we show them that we see their personhood and that we value them, even in the face of challenges. I will say that I have had not uniformly positive experiences around sharing the fact that I live with bipolar disorder. And just to say, I always say that I am someone who lives with active bipolar disorder, that I've been hospitalized multiple times, over the last 10 years, that I'm someone who has mood episodes. It's not something that I have overcome. It's a part of my life that I will continually live with. And it's an important part of my identity as well. So this image here is up from a time where I felt a lot of sort of discrimination from the place where I worked, because I had bipolar disorder, where I felt that I was overly scrutinized, where I hadn't had any issues in the workplace, but forced to do these very sort of invasive assessments. And this is really, I center myself as a provider in this talk because the way that we exist in community as healthcare providers, helping individuals, if we don't feel safe being our authentic selves, there's no way that we can support other people to feel safe being their authentic selves. And if we are sort of socialized into these biased perceptions of mental illness, those things certainly propagate to the people that we care for. And just to give you an example of this, so my sort of research and advocacy work are sort of deeply intertwined. And this is from this, I got to do a big talk that was very exciting, whatever. And I talked a lot about how the same parts of ourselves that medical culture compels us to conceal are exactly the parts of ourselves that help us heal. And in this talk, I sort of explore a lot around disclosure, around mental illness, around sort of stigmatized identities. I'm also gay, so around sort of stereotypes related to people who are gay. After the talk, I got feedback, and the feedback really could be split into two main sort of groups. One group basically says, oh, like, this is so important. This is the most, this is the best talk of the whole convention, all these things. And the other people who say, I am deeply worried about this person's stability and whether or not they can provide safe care. And I will again and again and again reflect back to this comment that the ways in which we are socialized as providers, they influence the way that we talk to patients, we see patients, that we view patients, and that we try to support patients. We know that people with HIV have higher rates of depression than the general population, that things like worsen, like uncontrolled depressive symptoms are associated with worse HIV outcomes, that there are interactions with diseases like bipolar disorder, which I said I had, with HIV risk factors. I'm a kidney doctor. I see the impacts of medications like lithium, which end up which have the potential to negatively affect the kidneys. Mental illness is a very, very sort of prevalent health condition across all populations, but is certainly enriched for folks with HIV. I would argue that many of the same systems that encourage help seeking for providers also can encourage help seeking for patients. This figure is supposed to represent many of the barriers which discourage help seeking. One, that many of our health systems are sort of very punitive and carceral when patients don't adhere to the things that we want them to do. We often view it from a problem with the patient and don't look at the systemic factors that can contribute to people not being able to take their medications, or things that may make it hard for people to get access to medications or other treatments. There's certainly intersecting forms of oppression, in addition to this is the figure talking about mental health related things, ableism, sexism, classism, racism, xenophobia, all of these things. They discourage people seeking help because people feel like they won't be seen as a human. They will be dehumanized when they seek treatment. And returning to this idea of critical theory, which I mentioned before, Paulo Freire often writes about, talking about how to sort of leave this oppressor-oppressed cycle that I mentioned, we need to strive towards true humanization, where we value all human beings for their intrinsic worth of who they are, and not because they do things like adhere to treatment or because they're good doctors, etc. I've talked a lot about mental health stigma and bias. And finally, this dehumanizing culture of medicine. I think one of the things that I have had a mentor that I deeply care for said to me is, if you don't believe that you can be exactly where the people that you're caring for are, you shouldn't be caring for those people. There are often ways in healthcare that we create this culture where we're supposed to be superhuman individuals. can work very intense hours, can do things that we wouldn't expect other people in society to do. And in so doing, we actually other ourselves, and we often will view patients as a different group than we view providers. And in so doing, that is an act of dehumanization. I'm going to get to some research in just a moment, but just sort of really wanted to open with this heavy story thread. Part of humanization is seeing individuals in their entirety, is recognizing that when people present to health systems and are seeking medical care, they're actually often on some of the worst days of individuals' lives. And we often miss the greater picture of who a person is outside of their medical care. So, for me as a, as a bipolar Black kidney doctor, when I'm in a psych hospital or receiving care as a patient, it's often very focused on the single problem, the reason why I'm in the hospital. And we lose the bigger picture, that I'm a uncle, a brother, a son, a runner, an educator, a partner, etc. And truly holding, there's one thing to know the facts about that, but to truly hold the depth of a human is actually incredibly hard, especially in a medical system which really focuses us on a single problem. Okay, so what I'm giving a lot of examples around mental illness, and I'm going to ask when we get later on towards the end for the audience to sort of reflect on any ways in which this feels applicable for patients with HIV or people with HIV. So I have two stories. I'm going to begin focusing on this idea of thinking about disclosure as a tool to humanize. So, so one day I was in my kidney clinic, and as a patient was leaving, they handed me a form. And this was a depression screener, a PHQ-9. This form basically showed that this person had quite a number of symptoms of depression. It's not like the depression was actually not very well controlled. And as I looked down at the form, the patient handed it to me, and when I looked up, they had walked away. And it was actually first in that moment that I learned that in kidney clinic, we screen for depression, because I actually didn't know. I'd worked in this clinic for almost a year, and I had no idea that we were actually screening people for depression. And immediately I will say, before I even get to my interaction with the patient, as a patient myself, this was actually very alarming, because from a systems perspective, the fact that we were screening for someone's mental health condition, that seems like it's a good thing, but there were no workflows to record someone's depression scores. There was no workflow of what to do if someone had a high score on this form. I had never been, I didn't even know that we were doing this. And in this way, this is actually a deeply not trauma-informed practice, because my sister once told me the story of how my family, we actually have a lot of mental illness in our family. And she says, she tells me about one day where she basically mustered up the courage to fill out one of these forms. And she was very honest. And then she said something, she even said some things that, were very kind of concerning. And she said, "Justin, no one ever did anything." And in this way, there are many, many sort of quality improvement projects that we sort of we take on and we put in our clinics, but asking someone to disclose trauma to you, and then not having sufficient processes to follow up on those traumas, it actually inflicts more trauma, and it makes people not trust health systems, because they feel that even when they have or do disclose things, that people don't actually follow through and help them. So, informed by this information, with my past experiences, my family experiences, I gave this patient a call later that evening, and she let me know that she had had depression for a long time. She had tried antidepressants in the past, and they just didn't work for her. I told her, it's okay, I want to disclose something, that I've taken antidepressants in the past as well. And sometimes it takes people a few tries to find the medicine that works right for them. And I asked her if it was okay if I could connect her with her primary care doctor, who could potentially, prescribe her medications to try and help treat her depression. I also say this to say, it is also not trauma-informed practice for individuals to take on loads of things that they are not able to sustain or continue to care for. It's very important as we think about how we care for our patients, how our health systems work in conjunction with each other. Because as a kidney doctor, I have done general internal medicine training, but I would say it is by no means in my sort of skill set to really titrate people's antidepressant medications. And so really being thoughtful about what we commit to our patients and the workflows that we create as we try to get people connected to care. I use this example of disclosure, and I'm naming the word disclosure as something that I think is highly underutilized in medicine. Often we as professionals view disclosure as sort of crossing boundaries. And I think many people, when they think of disclosure, they think of all the risks around it. And I'm going to talk about some of that in a bit. I want to introduce a term to the group, which is this term subjectification. So I think the simplest way to explain subjectification is as the opposite of assimilation. So much of professional training is developing a professional identity in which we are similar to the group of professionals which we are trying to join. So in medicine, physicianhood, you go from being a layperson to a physician, and that process is a process of socialization, where you take on the norms of the group, you learn sort of obviously medical knowledge and how to speak and all these things. You actually change your identity. Subjectification actually says, when are the times that we step out of the norms of our group and do things that are different, because we believe that it will positively influence the care that we provide to people? When are the times that we differentiate ourselves from our group norms? And I would argue that disclosure is one way in which we can subjectify. Subjectification is a complicated construct because if we believe that the health systems that we work in can be harmful to patients, we therefore, by definition, must have times where we subjectify, where we step out of the sort of group norms, the dominant practices, and do things differently. Otherwise, we're going to continue to reinflict pain and trauma and suffering onto people. But the question is, where is that line drawn? And this is the hospital that I practice at. It is a county hospital, which for us in the US means that people who are underinsured or uninsured, who don't have health insurance, and often people who come from sort of marginalized, poor settings, in this system, even though it is a county hospital which tries to care for these people, the broader healthcare system, in the US is not made to support these people. And still, people fear stepping out of their professional norms. And so some of the risks of subjectification. So I'm someone who's very pro-disclosure. I think that may be obvious. I often talk about, myself in contact with my patients. I try to do it in ways that are thoughtful without sort of dominating healthcare interactions. I think that is the first fear that many people have when they think about things like disclosure, that, we really want to focus care on patients. And also that we are not trained in thinking about things like disclosure. Oftentimes, when done not well, disclosure can just end up being what I call trauma porn, where people just sort of say really traumatic things just for the sake of saying them, without them actually sort of being clinically meaningful. And that is certainly a risk, in large part because we don't talk about or know how to do disclosure well, don't think of it as a trauma-informed practice. And I didn't give a definition of trauma-informed care or what it means, what I understand trauma-informed practices to be. And I will share again from a different mentor who said that trauma-informed practices ask us to hold the deep, immense sort of weight of suffering that people have experienced, and simultaneously hold for our patients the ability to heal. Our experience is having seen people heal, and allowing people to exist in the sort of darkest depths in which they are, but still holding that small light, and hope and knowledge that people will and can heal. And then creating practices which hold an awareness for people's past traumas, avoids re-inflicting trauma, and then helps to move people towards healing. So, okay, so now I'm going to give just a little bit of some studies that I've been involved with. This obviously is set in a very US context, but I think the principles apply. So this is a study actually not led by me, led by a colleague, Dr. Borowski, where basically we were interested in understanding, topics like race and racism amongst patients. And oftentimes it's unclear like whether or not patients want us to talk about these very sort of challenging topics with them. And when people don't see themselves represented in the providers who are caring for them, and that can be for a whole host of reasons, not just limited to race. I mentioned class, which I think is one that comes up again and again. Yeah, what do people want? So from this study, I'll give you, so this study was basically, we interviewed both patients and providers, and essentially tried to understand their perspectives around talking around challenging things like racism. One of the things that was a very important early centering topic is to recognize potential either identity concordance or discordance. This is the ways in which if patients see, the providers who are caring for them, if they see themselves like that person, that is a different interaction, that they see themselves different from that person. There are many times where, here, I once had a patient who was hospitalized, and this is when I was a medical trainee, a medical student, they had to go somewhere and they needed to catch a bus, and as they were leaving the hospital, and they were asking what bus, they were trying to remember what bus they had to take, and I told them the bus, and this person all of a sudden became shocked because they were so surprised that I knew which bus to take, because they asked me, like, wasn't I driving around in my like fancy car, like Rolls Royce or something. And in this way, even though I saw myself, a Black man talking to another Black man, as similar to them, they did not see me, they did not view me as similar to them, in particular in this sort of class way. And so I think it requires us to think about identity concordance beyond just sort of the simple one or two first demographics that we may often talk about. These types of conversations around challenging identity topics are opportunities for providers to demonstrate allyship and trustworthiness. When people are able to have these nuanced conversations and bring them up in ways that are thoughtful and helpful, it builds relationships. There's obviously challenges to this. When we think about talking about bigger structural issues or challenges that people have, patients are often worried about the time, and patients and providers, the time in an encounter. That when we're trying to deal with the different health challenges that a person is working on, that there are that if we make decisions to talk about things like race, racism, class, sexism, etc., that we're taking away from healthcare encounters. And in general, again, as I mentioned, in the U.S. context, people often can't bill for these types of conversations, and so it's not sort of supported by the health system to spend time talking about these things. And then finally, that there are some people who just don't want to talk about some topics with their providers. Some people want to just come get their health care and then leave. We have to make space to allow for conversations and also for allow people to opt out of conversations. So I want to introduce, I'm going to skip this, I'm going to come back to the slide in just a second. I want to introduce a construct to everyone called identity safety. First, to step back, I want to mention the term psychological safety. So psychological safety, you may have heard of. It is a form of safety that really focuses on hierarchy. And it initially arose in the business and education literature. And in that space, there's a lot of evidence that shows that when people don't feel psychologically safe, they're unlikely to disclose errors if they make errors. People are unlikely to challenge leaders, et cetera. With patients, there's often this role of being a provider versus a patient, that patients may not feel that they can speak freely or speak honestly, or may not want to say things because they're worried that, because there's not this sense of it being okay for them to disagree with or to not follow their provider's recommendations. Psychological safety is a very important sort of construct, but it actually is very limited when you think about identity. And specifically in psychological safety, my two main critiques of psychological safety are, one, the literature will say, once someone feels psychologically safe, then they'll bring the diversity of their identity. And I would say that that's not always true, because if someone doesn't feel safe to bring their identity in, they won't bring their identity in. And there's a lot of ways that people can sort of hint that someone is that it's safe or not safe to bring in their identity. So, for example, I think I've said I'm a gay man, and if a provider says to me, "Have you had receptive anal intercourse?" Versus if they say to me how I would say it, which is, do you bottom? Those two words signal very different things. And if someone leads with the first word, one, it shows that they don't sort of connect to my community and don't know the language, which is important for me. That in of itself, even if the person tries to be very approachable and friendly, I may not feel comfortable disclosing certain things about myself. The second thing about psychological safety that is sort of a limitation is that in psychological safety, you always need the person with more power to make the person with less power feel safe. And in that way, power is very unidirectional, that there's never a time where a patient can create safety for themselves or a junior trainee can create safety for themselves. You always need the person above them to do it. So enter identity safety. So identity safety attempts to sort of fill in some of these gaps. We define identity safety as a state where a person feels free to exist as their authentic self, without needing to self-monitor or change their behaviors. And identity safety arises when there are three main core needs met. There is an within the individual need, there's a between individual need, and a community level need. So within the individual, so first I'm going to talk about this from the provider side, and then I'll relate it to the patient side. So on the provider side, agency to serve refers to the ways in which people draw on their own identities, their own experiences, in the spirit of patient care. And when people are able to draw on their own identities to help patients, it creates a sense of value or worth of why they are the perfect person to be existing in a given space with a given patient. And there are many times, I think anyone who's providing patient care, there are times where our identities allow us to connect with people in ways that help make it easier for us to help them. And this disclosure, like I was mentioning before, is one of the ways that we can demonstrate agency to serve, but there are many other ways. There are some times where we don't even have to say anything, that you walk in a room and you have a shared identity with a patient just from looking at them, and that allows us to help care for them. Upholding personhood refers to instances where we make people feel seen, that we see them, that we value those identities, all in the picture that I showed with, all the different things that matter to me. But we also know that there's a person who's more than just the sum of those identities. And finally, belonging. There's two main thoughts of belonging. The first is, I am similar to these people. I have identity concordance, so I fit with these people. And the other is, I am welcomed as my authentic self into this group. We adhere to the second definition of belonging. Identity safety, when providers feel identity safe, there's a lot of evidence that that improves the care that we're able to deliver to patients. I'm actually working right now with on a study with an ID doctor at University of Washington. We're basically trying to describe this construct of identity safety amongst patients. Specifically, and there's a lot of all of these. There are many ways this should and likely will relate to patients. There are some times where, where patients may not so for instance, one way that someone could draw on their identity is a time where they teach their providers. There are some patients who say that they actually don't like that very much. Like there's a lot of literature around trans folks, that it's not fun to have to teach your doctor about hormone replacement therapy or all the things that they need, all the things that a given person would need for care as a trans person. So we're curious to sort of unpack and see more, think about what this agency to serve means for people. A way that I imagine that it will show up in this study that is actually in the early stages right now, is there are times where people draw on their identities to connect with other people, where they have a community, for people to have community, or to help other people with new health diagnoses. Going back to the slide of this, healing is not linear. I think often, I would certainly say myself, and I've certainly seen it in health systems, we sort of expect people to walk along this very linear path of, from being ill to being healthy or to processing trauma. And the reality is, healing is not linear. As a bipolar person, I have mood episodes. I have cyclical mood condition in which I do better and worse. And I think really being able to exist in this state of sort of uncertainty and sort of turmoil, but also continuing to help guide people. I think this is a very important role that health professionals play. So I'm hoping at the end to just sort of have some time, 20 minutes, to just like get people's thoughts, critiques, like, any comments whatsoever. But I want to end with this. I wrote this title, Communicating Through Identity, Stigma, and Trauma. And I think there are sort of at least two ways of thinking about through. You could say that you're communicating through these things that in a way that means, I'm communicating like in spite of, or you could say I'm communicating by way of. And for me, by way of means that we're not trying to go around these aspects of identity or lived experiences, that we're actually unpacking them and moving through them by way of them to help heal. So those are all the slides that I have. I would love any thoughts or questions or comments if you have any.
Thank you, Dr. Bullock. That has been, I think, a really impactful session, because it sort of, forces us to think deeply and reflect deeply on how we approach, the care we provide the clients that we have, and the diverse identities and the diverse source of trauma that we would have experienced. And particularly sometimes from a healthcare community that is not particularly minded, to recognize who they are and what they've been through. So thank you again. That was a wonderful session. I will open the floor for questions. I don't like to ask the first question, so if they have many, but I will open the floor. Anyone who would like to put up their hand or type in the chat box or ask a question, please feel free to do so. Oh, David, go ahead. Hi, David. I'm seeing your hand raised. Unmute, and you can go ahead and ask your
Oh,
question.
yes. Okay. Thanks, Gregory. Thanks so much, Justin, if you don't mind me calling you by your first name, for this very, very beautiful and illuminating talk, which reminds me of my good old days of as a young doctor, when doctors were going around reviewing patients, and instead of saying, "This is Dr. Justin Bullock," patients were often referred to as, "This is a case of diabetes," or "This is a case of leukemia," or "This is a case of what." And it made me wonder, have we even taken time to explain to these people what we are talking about? And getting older and being in practice, I have realized how traumatic a diagnosis doctors might think is very simple is to the patient. I remember telling somebody that your sugar is high, you're diabetic, and they broke down and cried helplessly. And these are some of the things we don't take into consideration in our practice. And the other bit is how much we don't disclose anything to our patients. But you've talked about something, and I'm going to ask you something which might be personal, might be general, and it's this concept of being suicidal, because I've always thought that to be suicidal and even to go ahead and commit suicide is not an easy thing from an outsider. But for the person, it seems to me, or I have the impression that for somebody to commit suicide, they think, or they're at a point where they feel that they're going to have absolute comfort if they succeed. What is your thought about that?
It's a great question. I have a quote for you that hopefully I will be able to not mess it up too much. So it's from a gentleman named David Foster Wallace. He's a writer who actually ultimately died by suicide. But in one of his books, he wrote this piece that it basically says he compares dying by suicide from he compares it to jumping from a burning building. And he says, make no mistakes about people who jump from burning buildings. Their fear of falling is just as great as it would be for you or for me standing at the same window, speculatively looking out at the view. The variable here is the fire's flames. And nobody standing on the ground looking up, yelling like, "No, hold on," or "Don't jump," can understand the jump. He says, I'm sort of messing up at the end, but basically you have to have truly felt the fire's flames to understand a terror beyond falling. And I sort of butchered that quote, but essentially, for me and my experience, and recognizing that everyone's experience is different, my mental illness, when I'm unwell, I'm just very, very deeply suffering, and it's very hard to explain what it is that is suffering within me. But my family is interesting. So once when I was not well, I went to go live with my sisters for a bit, and they just watched me just like sobbing on the couch and just crying like for hours and hours and hours. And I would get up and I would I was in med school at this point. I would go to school, I would do everything that I needed to, and come back to the couch and immediately be like return to where I was before. And I think it just wears you down. My depression, it just wears you down over time, and you get to this place where you don't have hope that things will ever get better. And so it's for me less, and there's a point also where I think part of the illness is that suicide feels like this hyper rational thing, where you have a problem, you're suffering, the suffering is not getting better. For me, it's like I was running like 80 kilometers a week. I was going to therapy multiple times a week. I was taking meds, all these things, and nothing has gotten better. And so it just feels like there's a solution that you have that can end the suffering that you're experiencing. And yeah, so that's my experience of, and at some point also, I think it's just like in any setting, if you were to, when you tell, like, your mind, like you're thinking sort of through suicide, when you tell yourself things over and over and over again, at some point it begins to sound normal. Like, when you initially have this thought of like hurting yourself, it's very like, it feels very it's ego dystonic. It doesn't fit with how you know yourself. But after it happening for, like days and weeks and months, etc., it begins to feel like it's less of a crazy, for lack of a better word, less of a crazy idea after time. Yeah, please. Sorry, hand raised. Please. I want to hear what you're going to say.
No. I think I was putting my hand down. Thanks.
Okay. Yeah. So I think that's and again, everyone experiences it differently. For me now, I've been through multiple mood episodes, and part of the experience now is actually one of knowing how bad things have been in the past. There's just really a really deep fear that I'm going to enter this very, very horrible suffering place. And a lot of my thoughts of harming myself sort of relate to that. But like, I'm not strong enough to take that experience again.
Thank you for that, Justin.
Thanks for asking.
Rosanna, they put something in the chat box. So from Rosanna Forbes, I'm really happy for the presentation and how real you were. Because a clinical professional, some person take a long time to share. You're 1 in a million, thanks. So thanks, Rosanna, for those guiding words. I wonder if I can just reflect on 3 things that sort of stuck in my mind from the presentation we gave. The first thing was when you spoke to the way we are socialized and trained affects how we see our patients and our ability to relate to them as persons. That's first thing. Second thing, the anecdote you gave about, your patient being shocked that you knew which bus to take. And how that showed that, the way he was socialized as to who he is and who a doctor is rendered him unable to see you as a person, and so he was part of this monolith that is medicine and medical professionals. And that sort of breakthrough that he had over something as simple as this person takes a bus just like me, might have deepened your ability to relate to him and him to you. How do you think, from a systems perspective, we can enable those little moments of recognition to happen in both directions, so that the doctor-patient relationship is it's still a medical expert to a non-medical expert, and as you said, persons of trans experience are not that happy having to educate their professionals as all the issues with respect to gender affirming care and hormone support and so forth. But how do we try to allow our patients to see us as persons, so they can relate to us as persons, and this person I might be willing to open my mouth and let this doctor, this social worker, this psychologist, this other medical professional know the pain I'm going through, because I'm tired of going through the pain, but I'm not going to reveal my pain to someone who's just going to bounce it back at me glibly.
It's a great question. And in hopefully in like 4 months, I'll have a better answer than I'll give right now. So in the identity safety sort of figure that I showed, that was from a study with medical trainees, and people talked a lot about the power of the like very human moments, like sharing a meal, as times where they got to just be very normal, like be themselves with the people who they were around. my sort of unpacking of that is, I think it's a very, like, humans need to eat. It's a very human thing to do, to like break bread with someone. And so in the training setting, that was an easy way for people to sort of build connection, because that's when they would often just like talk to people and not talk. Typically when you're in settings around other people, you can't, you're not talking about patients. So it tended to allow for more human interactions. And so I think the question is, how do we create these human interactions with providers and patients, recognizing that everyone has limited time and desire and all these things. And I think one like small thing could really be for people to, if there was some way where patients could access profiles of the people who they are caring for. And most of the profiles that I see nowadays are like, I really care about like kidney stones and acid-base disorders, whatever, all these things that are, they're obviously clinically useful. You're trying to figure out who's going to help take care of you for which problem you have. But there's missing a lot of the human aspects. One of the, so I think that, so first, that could be in the form of like, if you have a written thing about someone where they could write sort of who they are, and people would like to get to know their providers. You can make, if there are like videos, you can make a video, like a short clip where someone gets to sort of talk about just who they are as a human outside of medicine, and sort of make that easily accessible for people, or make it sort of visible in the clinics where people are. One of the risks of disclosure is sometimes disclosing things can distance yourself from patients. So in one of our studies, we have someone who, I'm in Seattle right now, someone who grew up in a wealthy suburb outside of Seattle, and a patient, and they mentioned that they were from Seattle to a patient, and then the patient said, oh, like where? And then they told them the actual neighborhood. And then the patient was kind of like, whoa, like, okay, that's a very fancy, and so in that way, that person felt like they actually distanced themselves. They wish that they hadn't sort of shared that part of themselves with people. And so I think it's a little bit, it's obviously complicated to think about what you do or don't share, but also recognizing that, like Justin, I want to be a great doctor to any patient that I see, and I may not be the best kidney doctor for every person, and allowing people to see more of who we are so that they can make decisions for themselves. And I guess I didn't say this in the talk. One of the big things about identity safety that came up was that I kind of hinted about identity concordance. There are times where people are identity concordant and they don't get along, and so they don't feel identity safe around each other, and so there's risks that if we like show a lot about patients, people might go, they might pick some, they might try to get care from someone who, it sort of depends on the setting if they have the ability to choose who's caring for them or not, but there are stereotypes in both directions. That patients may hold stereotypes about us and our identities, and likewise we may hold stereotypes about them and their identities.
Thanks very much. That was very, very, very helpful. Thank you. I am seeing some other stuff in the chat box. So from Belinda White, I appreciated the point made that disclosure can be used as a tool to enhance client engagement, while appreciating the fact that disclosure should be done mindfully and intentionally, as it can also derail the engagement. Thanks, Belinda, for that. And from Kathy Ann Ford, thank you. Your lived experiences are truly invaluable, especially when proving meaningful interventions. I appreciate how you have embraced your vulnerabilities and used as a tool of advocacy. Thanks, Kathy Ann, for that.
Thanks for both of you. And I have a comment. I want to give one time where I did it very poorly. So once I had a patient who had recently been released from jail. He was seeing me in clinic. And my father's in prison currently. And I basically said to him something along the lines of like, oh, like I saw you recently were let go of jail. Like my father's in prison. And it was just not a bonding moment whatsoever. And that was just I was trying really hard to like connect with this person, and it was done in a way that just was not very retrospectively. I wish I had done that differently. I was trying to show him that I wasn't judging him, and that like, you know, and that I value, and that not that I value that is an experience that many humans have. So yeah, I definitely have bumbled many times. David, please.
Yeah, and then as we're talking about bonding with patients, sometimes it's a matter of time, because sometimes when you meet the first time, you really don't know the patient. The patient doesn't know the doctor. I remember one particular patient, we became quite friendly later on. And then when we reached that point, he actually opened up to me and told me that the first time we met, I don't know whether he used the word that he hated me, but he was frank enough to tell me that, in fact, I did not like you at all. But later on, as we continued to interact, and I met his wife, and later on met his son. I mean, before the wife became pregnant, anyway. Then we became quite close, and we interacted very, very nicely. And again, Justin, as you've said before, there are some people who just want to come. They've come for their prescription, then they wanted the prescription, and they go their merry ways. And in an attempt to bond with them or to explain to them some things that you, as a physician or a clinician, you might think are important, you basically get the impression that you're stepping on their toes, because they didn't come to listen to that. They just want to go. So sometimes it just helps, give them their prescription, they go their merry ways. And then there are the other group of patients who might want to find ways and means of talking. And in that process, they open up to you, and you might find quite a few things that they never reveal to anybody. For example, you might meet somebody who's been in the clinic, maybe the renal or HIV clinic, on a particular medication, and they have side effects for the medicine they're taking, but they've never opened their mouths to tell somebody, maybe until 1 or 2 years later. And if you try to find out from them, but going through these horrible side effects, how come you never mentioned this to anyone? And you can't explain as a clinician why they or what made them open up to you at that point in time. But maybe again, it borders on how you relate to them, how they feel safe with you, and how they feel free with you enough to talk and tell you whatever they need to share with someone. Over.
Agree completely.
I saw someone hands was raised, but I think they may have left the meeting. I'm sure now. Maybe she'll come back, hopefully.
Well, I thank you all very much. I'm very grateful for getting to join you all. I love the thought. These are very helpful for me, you know, as I am for, you know, the work that we're working on right now to think about. So I'm grateful for these comments.
All right. So again, I just want to thank everyone for coming, and thank you for participating. I think as is usually the case, you know, we always have these rich, deep, and meaningful discussions that are echo sessions. So again, I just want to thank everyone particularly for, you know, for contributing and for tuning up and for making the comments and for asking questions. If there are any questions that maybe you're too shy to ask, you can always email any of us, and we can direct the questions to Justin afterwards. And we just some housekeeping notes. So I think there are 2 more sessions for this cycle. The next session will be on July 26th, which is again the Saturday, not the 7th, it's the 4th Friday, because we weren't able to manage the 3rd Friday in July. So we hope to see you again at that session. Thanks again for coming. Spread the word, invite your friends. It's fine. We're family here. And again, I want to thank Dr. Bullock for coming and giving us this really insightful session. So I just hope everyone has a good evening. Be safe, be well, watch the weather, make sure you have an umbrella and maybe your galoshes in case you get some little flooding. And that's it for us at our MRFTT STI session. Hope you have a wonderful weekend. Be safe and be kind. Take care. Bye-bye.
Thank you.
Bye-bye.
Thanks, everyone.
Thank you.
Bye-bye.
Thank you.
Bye.
Bye, everyone. Cheers.